Hello, good morning and afternoon, everyone. I'm hoping your Wednesday is going well. We'll get started in just a minute here to give folks a moment to connect, but I would love to see who we have joining us today. So please introduce yourself with your state in the chat box and feel free to share your favorite heart-healthy snack as well. And make sure if you want everyone to see your chat to change that to everyone. It defaults to only to the panelists. So let's see where you all are joining from. I'm Kaing Nguyen. I'm tuning in from Denver, Colorado, and my favorite snack these days is pistachios. I can't get enough of them, although Dr. Bond, I don't know, maybe that's not good. Maybe I do need to cap that, but my favorite heart healthy snack these days is pistachios. Great, looks like we've got Georgia, Texas, Indiana, Washington, DC, Washington, Ohio, lots of folks joining us, and apples are great snacks. Thank you. So it looks like we've got a nice mix of people here. So I'm going to go ahead and get us started. Thank you for joining us for today's National Conference of State Legislatures webinar, Maternal Health and Cardiovascular Disease. My name is Kaing Nguyen. I'm a project manager in the health program, and I'll be your moderator today. Before I introduce our speakers, I want to review a few housekeeping items. Today's webinar is a platform for information exchange and engagement. So over the next 60 minutes or so, we encourage participation through our chat box and Q&A boxes. The Q&A box allows upvoting, so please ask questions for today's speakers using that option. And you can use the chat box for general questions or to connect with other attendees. And again, make sure to select, whether you only want to send your chat to panelists or to all attendees. And if you're just joining us now, please take a moment to introduce yourself and type your state into the chat box. We'll hold a formal Q&A after all our presenters are finished. Today's webinar is being recorded and will be available on NCSL's website, along with a PDF of the slides within the week. We'd also like to thank our partner Amgen for their continued support of our work in this area. So today's webinar is on maternal health and cardiovascular disease. Cardiovascular disease, including heart disease, stroke, cardiomyopathy, and other conditions, is the leading cause of death and contributes to significant morbidity for pregnant and postpartum women in the US. Joining us today are three experts who will discuss the current landscape of maternal cardiovascular health, as well as programs and policies that address this to prevent maternal mortality and improve women's health. We have Dr. Bond, Dr. Veronica Gillispie-Bell, and Eric Skinner. For full speaker bios, please see the attached document in the chat box. Eric, please attach the bios for everyone. Thank you. So first, we will hear from Dr. Rachel Bond. Dr. Bond is a board-certified cardiologist and the system director of women's heart health at Dignity Health in Arizona. She serves in leadership roles in the state and national chapters of the American College of Cardiology and the Association of Black Cardiologists. Dr. Bond, thank you so much for joining us today. The floor is now yours.
Thank you so much. It's an honor to be here. And I am going to just very briefly be going over kind of the when we think about particularly maternal health, it's always important to also highlight cardiovascular disease, because irrespective of maternal health, cardiovascular disease is the leading cause of death for those both male as well as females. And many of the conditions that occur during pregnancy, as an example, can dictate one's future cardiovascular risk. So I'm going to delve into a little bit of that, but more importantly, furthermore, delve into a lot of the policies and medical positions that the societies that I have the honor to be a part of are working on in terms of collaboration to handle the despairing numbers that we're seeing when it comes to maternal mortality. If you could advance the slide, please. So I'd like to begin actually first by really emphasizing the fact that it's shocking in the United States as it stands that we're seeing higher pregnancy-related deaths than we actually did back in the 1990s. And I think a picture is 100% worth 1,000 words, because here we see a series of comparable countries. And as it stands, the United States has a 2-time greater risk of pregnancy-related death compared to other countries that are deemed to be first world. Next slide. Next slide. And when we actually look and delve into the leading cause of what that maternal mortality is coming from, we know that cardiovascular disease is leading the way. And when we think about cardiovascular disease, that's a very broad term. That could include a cerebral vascular event, such as a stroke. It could include a heart event, such as a heart attack or a blocked artery. It could also include a possible plaque buildup in the arteries of our extremities, be it the upper or lower extremities. And when we actually delve into the percentage of pregnancy-related deaths that are accounted for by heart disease, it's nearly a third at 26.5%. The most common cause is from peripartum cardiomyopathy, which is a weakening of the heart muscle. Thereafter, any hypertensive disorders of pregnancy and stroke very commonly lead the way. And what this translates into is that nearly 1 in 3 deaths actually are occurring from cardiovascular disease. And again, this is despite the United States spending nearly 2.5 times more per person on health than any other developed country. And when we think about maternal mortality, it's actually just the tip of the iceberg, because for every maternal death, there are about 75 to 100 more women who suffer life-threatening complications during pregnancy or childbirth. And when we think about the disparities that exist, why cardiovascular outcomes are so poor, and why is that the leading culprit of mortality when it comes to these pregnant women, it's important to highlight that as it stands right now, we know that the leading risk factors include one's age. We know that the older you are during your pregnancy, the higher your risk. We know diabetes is another risk factor. High blood pressure is another risk factor. But the last risk factor, which people don't necessarily think about, is race. And when we think about the race being a risk factor, it's less likely the genetics of that, but more of the social aspects. And when we think about the morbidity and mortality, we know that non-white women and lower income women have the highest rates of cardiovascular morbidity as well as mortality. And when we focus in on which race in particular, we see that Black and American Indian women are 2 to 3 times more likely to die during pregnancy and that postpartum period compared to white women. Next slide. Now, the changing philosophy, and why is it important that we have a changing philosophy? Because there is good news. The good news is that 60% of pregnancy-related deaths are preventable. And when we think about cardiovascular disease as a whole, it's a condition, although the leading cause of death right now in the United States, that's preventable 80% of the time. So we can do better. Next slide. And I think it's important to highlight ways that a lot of societies are trying to actually make sure we start doing better. One thing that I'm really very appreciative of is that the American College of Obstetrics and Gynecology has since joined forces with a lot of our cardiovascular societies, including the American Heart Association and the American College of Cardiology, to come up with clear guidance on which patients may be at highest risk and what that really follow-up and surveillance should look like. And as it stands right now, many local states are doing a phenomenal job in lowering the rates of maternal mortality. As an example, I bring to forth an algorithm that was set forth by the California Department of Public Health. This was through their California Maternal Quality Care Collaborative of Cardiovascular Disease. And here they highlight symptoms to look out for, vital signs such as abnormal pulse rates and elevated blood pressures, even risk factors. And within that risk factor, again, is race, with the African American race being highlighted as a potential risk factor for poor cardiovascular outcomes. It also highlights the use of a physical exam where we're actually auscultating and listening to the patient's hearts and lungs. And one thing that I think is so important is that it talks about the use of a lot of standard cardiovascular testing, which allow us to actually identify disease earlier on. And one thing that I want to emphasize is, in addition to us doing this throughout that pregnancy, it's such a pivotal point that we have to also maintain this same vigor in that postpartum period. And it really should be up to 1 year postpartum, because what we are seeing is that a third of pregnancy deaths are occurring in that postpartum period. And what's leading the way with that late postpartum mortality is actually that peripartum cardiomyopathy, which is that weakening of the heart muscle. Next slide. So as it stands right now, what we are in the cardiovascular and obstetrics community are really focusing in on our maternal heart teams. These are teams that are joined with obstetricians, cardiologists. Sometimes they also encompass the primary care provider as well, where we're following the patient throughout the maternal heart continuum or the maternal health continuum, meaning not even just during pregnancy, but more importantly, even in that preconception period prior to conceiving, where we could hopefully optimize any of those risk factors I highlighted: high blood pressure, obesity, cholesterol issues, insulin resistance, and give them guidance on if they may be at risk for adverse pregnancy outcomes. We're able to identify any of these adverse pregnancy outcomes rather early. And when I talk about adverse pregnancy outcomes, this includes hypertensive disorders of pregnancy, including preeclampsia, where the blood pressure is very elevated and we may have evidence of end organ damage, gestational diabetes, preterm delivery, or even having an infant small for gestational age, as well as placental abruption. Those are adverse outcomes that can actually place a mother at a higher risk for cardiovascular disease in the very immediate future. And I highlight immediate because it's within the next 5 to 10 years. So these are moms that really need to be in the hands of a cardiology specialist, making sure that we're actually screening for any traditional risk factors, which we could again optimize. Next slide. Now, one thing that I have the pleasure of doing in my own health system in Arizona has actually created a council that looks at this, and it looks at it in every really aspect of the maternal health continuum. Acute care, which is really the focus in the inpatient setting, where again, we're educating the emergency medical providers, the intensivists, and even the hospitalists on the signs and symptoms of cardiovascular disease to look out for, and utilizing a lot of our imaging studies or even basic laboratory data that can help identify these mothers at greatest risk. We're making sure that in the ambulatory care setting, the obstetricians are screening for any of these conditions. And if a patient has evidence of it, they're thinking about collaborating with the cardiologist. We're also making sure that any of these mothers who have had complications during their pregnancy have establishment in that postpartum period to make sure that they're establishing with a heart specialist, or at least that they don't have fragmented care. If the care is going to be transitioned from the obstetrician to the primary doctor, that's actually happening. And lastly, from a preconception perspective, this is really where collaborative care is key. And again, the vision of what we want to emphasize is that it's so critical that this is occurring during that first year postpartum, because it's up to 1 year where we're seeing a lot of these disparities. Next slide. Now, one thing that I'm extremely so thankful I had an opportunity to participate in is through my chairmanship at the Association of Black Cardiologists, was a roundtable that occurred in 2020, specifically June of 2020, where we had a series of industry partners, as well as organizations, as well as the Black Maternal Health Caucus, who joined forces with us. We had a sit down to highlight the fact that Black women are dying at disproportionately high rates from cardiovascular disease. But what we, with our roundtable, really wanted to address was solutions to fix this. And if you go to the next slide, through this roundtable, we were able to actually have an opportunity to publish our solutions in Circulation, Cardiovascular Outcomes journal back in February of 2021. And what that journal allowed us to highlight is that race and ethnicity, along with social determinants of health, can increase the risk for gestational diabetes, the peripartum cardiomyopathy, cesarean deliveries, preterm deliveries, and low birth weight, while independently increasing the risk of future cardiovascular disease. And when we think about social determinants of health, we know that those are the economic and societal conditions that affect one's health outcome. When we think about it as a whole, we know healthcare is dictated 60% more likely by these social determinants of health, and even genetics, or even underlying medical conditions as a whole. And although social determinants of health alone cannot explain the Black maternal health crisis, and we know overall lower income women do have higher rates of morbidity and mortality, when we actually specifically look at Black women, we see that the highest mortality overall is independent of their income, level of education, and as well as geographical location. And a lot of times the long-standing public policies and laws and structural racism, which I think is truly at the core, has produced a lot of the inequities that we see when it comes to social determinants of health, such as education, employment, housing, and transportation, that has definitely impacted healthcare systems. To that same point, we know that extreme and cumulative biological stress has exacerbated this, not just through misogyny as being a female, but also discrimination as being women of color, as an example. And this is a phenomenon known as superwoman schema, where extreme stress, chronic stress, can absolutely make patients more vulnerable for premature conditions such as hypertension or heart disease. Next slide. So policies that we have set forth, or really we hope to hone in on, is really utilizing trusted members in the community. We know that the use of, as an example, the faith-based community, when it comes to the African-American race, particularly, maybe empowerment will allow for education, but also empowerment. So thinking about incorporating them as well into that maternal heart team. Beyond that, we know mirroring data collection efforts, like as an example, what California has done a phenomenal job at doing. But even to that same point, what the Black Maternal Health Caucus, through their Momnibus Act, has really tried to acknowledge is that we want to hold clinicians accountable for poor outcomes, as well as health systems accountable for poor outcomes as well. We want to encourage collaboration between many of these healthcare organizations. And something that we in the clinician world really focus on is something called cardio obstetrics, where again, we have a cardiologist and an obstetrician working together. One thing that my local organization at the Association of Black Cardiologists is really trying to hone in on is really redefining what should be a target blood pressure, where we as doctors actually start managing and starting them on treatment. Should it be based on what our guidelines suggest, 130/80? Because as it stands right now, a lot of the GYN and OB societies are still utilizing 140/90. And a lot of data is saying that sometimes even lower blood pressures can have poorer outcomes, such as preeclampsia during pregnancy. We want to also figure out the ideal time for counseling, follow-up, and surveillance from that fourth trimester, which is that pivotal 6 weeks after delivery. But even beyond that, because as I said, it's up to 1 year where we can see these outcomes. We know that encouraging collaboration with nurses, midwives, as well as doulas, most importantly in women of color, is such an important piece, and making sure that these are covered by their insurances, I really do truly believe will help improve these outcomes. We even want to go as far as primordial prevention, meaning even before disease starts. And that's where incorporating pediatricians into the messaging may be important, making sure that we're giving a lot of good guidance to those children to make sure that they don't have any diabetes, high blood pressure, or cholesterol by the time they're thinking later on in life about starting a family. And deploying a healthcare workforce that displays diversity of backgrounds and experiences, modify medical education without a doubt, that includes cardio obstetrics, but also making sure that it eradicates structural racism and provides implicit bias training, expanding research and registry data, and focusing even more on vulnerable groups such as our active military and veterans, or incarcerated women, women who live in rural areas, and those who identify at the LGBTQIA+ community as well. And lastly, focus on mental health care and social services. If you move to the next slide, this very nicely shows one thing that we have been really impactful in doing at my local institution. Next slide, where we have an opportunity to create a passport where we go through a lot of this information. We provide it to the patient in preconception, during their pregnancy, or even postpartum. The next slide. And they have the ability to actually understand the warning signs. And next slide as well. And even document their numbers, because we need to make sure that close follow-up is there. And moving to the next slide, which is my summary slide, I think for me, maternal health is experiencing an ongoing crisis in the United States, and it's disproportionately affecting women of color, especially Black women. Having those collaborative teams in place, ranging from cardio obstetrics, with the inclusion of pediatricians, along with doulas, midwives, and trusted community members, possibly can mitigate this. We also know, of course, that we have to understand the role social determinants of health play, especially when focusing on access to quality health care. One thing that I think that we have to emphasize is, again, that fragmented care is what's leading to a lot of these poor outcomes. We want to make sure that there's full coverage, but equitable coverage and quality coverage throughout the whole maternal health continuum. And beyond that, improving health literacy, focusing on the importance of preconception counseling, as well as that critical first year postpartum is going to be key, because our goal is to ensure when we're executing solutions, they are unique to our country, our state, our city, our county, that individual health system, and most importantly, our patients. And if you move the slide forward, it very nicely highlights a mission and a message that we at the ABC, or Association of Black Cardiologists, are trying to do, which is a social media campaign called #ABCardioForMoms, where a key to improving Black maternal health is actually acknowledging Black mothers' concerns. Many a times they are not listened to, and at the end of the day, we know that that factors into these poor outcomes. So in conclusion, I thank you so much for today. We know that pregnancy, childbirth, and the postpartum period will always carry some risks, and we know that we can do better to minimize these risks and help ensure that mothers and their babies thrive throughout pregnancy and childbirth and for the rest of their lives. I look forward to questions. Thank you.
Thank you so much for Dr. Bond for all of that very helpful information. You packed a lot in there, and I learned a lot, so thank you. And next up, we will invite Dr. Veronica Gillispie-Bell. Dr. Gillispie-Bell is a board-certified obstetrician and gynecologist and associate professor at Ochsner Health in New Orleans. She is also the medical director of the Louisiana Perinatal Quality Collaborative and Pregnancy-Associated Mortality Review for the Louisiana Department of Health. So Dr. Gillispie-Bell, thank you so much for joining us today, and I'll turn it over to you.
Thank you so much, and thank you all for having me today. I'm going to be talking about the impact of COVID-19 on maternal cardiovascular health and giving you the perspective from Louisiana. So first, I'm going to talk about cardiovascular maternal health in Louisiana, what we know, and this is based on our maternal mortality review. And then I'm going to talk about how we use that data for improvement and the work that we've done through the Louisiana Perinatal Quality Collaborative to improve maternal cardiovascular health, but then also talk about how COVID-19 has impacted our mothers. So as Dr. Bond has already mentioned, we know that hypertensive disorders are increasing in the United States. And particularly when we think about hypertensive disorders in pregnancy, they are rising at a rate higher than that of chronic hypertension. And we're not sure if this is because many mothers are delaying pregnancy and childbearing to later age, or why we're seeing this trend, but we do know that this trend is impacting our outcomes and is consistent with that rise in maternal mortality that we're seeing across the United States as well. So from Louisiana, what we wanted to do, and this is published data from August of 2018, we did a quick review on our maternal deaths from 2011 to 2016, looking at just pregnancy-related causes. We now subsequently do a much more comprehensive review, but for this quicker review, we just looked at pregnancy-related deaths. And we found that the leading causes of death were hemorrhage and hypertension. Hypertension meaning cardiomyopathy, cardiovascular conditions, preeclampsia, eclampsia. And the other thing that should not have been as shocking as it was to us, because this is the trend that we see across the United States, is that Black women were dying at a rate 4 times higher than that of white women, with cardiovascular conditions being the leading cause of that. I think one of the other things, and I didn't have it on the slide, one of the other things that we found in doing that review is that 45% of those deaths were preventable. So that meant that there were things that we needed to be doing as a state to improve our outcomes. And out of that, and one of those things is the Louisiana Perinatal Quality Collaborative. You heard Dr. Bond mention the California Maternal Care Collaborative. And so this is the Louisiana Perinatal Quality Collaborative, very similar. And so the LAPQC, as we call ourselves, is a network of perinatal care providers, public health professionals, patient community advocates that all work to advance equity and improve outcomes for birthing persons, families, and newborns in Louisiana. And again, we really do the process of taking that data that we find from the maternal mortality review. And then the LAPQC is that improvement arm, using improvement science, working with our birthing facilities to improve our maternal outcomes. So our very first initiative that we did through the LAPQC was reducing maternal morbidity. And again, we looked at that the report that we had, the maternal mortality report, finding hypertension and hemorrhage being the two leading causes of maternal mortality, but also understanding that, that we had a disparity in deaths. And so from that, we came up with our goal of achieving a 20% reduction in severe maternal morbidity in patients who experience hemorrhage and/or severe hypertension in our participating facilities between August of 2018 to May of 2020, but also to narrow the Black-white disparity gap. It was important to us going into this initiative, and as the LAPQC was launching in 2018, that we were addressing not just maternal mortality, but also the fact that we had disparities. A lot of other collaboratives and even AIM focused more on medical conditions, hypertension, hemorrhage, VTE, those things, and then thought about the equity part as a separate component. But it was important for us to make sure that that was integrated into our improvement work, understanding that if we weren't improving the outcomes for Black women, then we were not improving the outcomes for the majority of women that were affected by these deaths. So what did we see through this Reducing Maternal Morbidity initiative? And again, just to back up just a little bit, in our initiative, we had 31 of our birthing facilities that were a part of our Reducing Maternal Morbidity initiative, or our MMI. Our numbers are now up to 42, but in the beginning we had 31 birthing facilities on board. And through a model called the Breakthrough Series, which is through the Institute of Healthcare Improvement, the LAPQC works with birthing facilities to make sure they're putting the processes and the structures in place to improve outcomes. And again, we use improvement science to help them with implementing those best practices. We know that evidence-based medicine, whenever we do translational research, it takes 17 years to put that evidence into practice. If you use improvement science and quality improvement techniques, it takes 3 years. And so that is what we did for our birthing facilities. And so what we saw is that the severe maternal morbidity, or having a severe bad outcome from hemorrhage, decreased by 39%. And then from hypertension decreased by 22%. That was our interim result. Now, our interim result, that was before COVID. And so if we fast forward to our next slide, we'll see our final results. So our final results, we saw a decrease in hemorrhage by 35%, specifically by 49% for Black women and 16% for white women. Now, our severe maternal morbidity, when we looked at our final results, we had decreased that for hypertension by 12%. Remember, before COVID, it was 22% when we did our interim results. But at the end, in May 2020, which was in the middle of COVID, we were at 12%. And we actually saw an increase by 8% in our Black women. And so why did this happen? Why did we see such a drastic change in our outcomes? And so we'll kind of talk about some things that I think led to that. Again, before COVID, we saw that reduction in severe maternal morbidity by 22%. And then at the end of COVID, it was 12%. Now, in working on improving these outcomes, again, we worked on process measures. What is the best practice to help reduce that severe maternal morbidity? For hypertension, it really is about making sure you're improving readiness so that you are acknowledging and recognizing those patients that have signs and symptoms of severe hypertension, and that they are getting timely treatment of their blood pressures. And so we can see that throughout the initiative, the process of improving that timely treatment of hypertension increased by 211%. And that was consistent throughout COVID. It was high when we initially started, it was very low, but even throughout COVID, that number did not change. And we saw a substantial increase in improving timely treatment of hypertension. So one of the things that I do think affected our outcomes, and we do see this now with COVID, this was something that I suspected being a clinician taking care of patients, pregnant patients with COVID. We were noticing that all the patients that were coming in that were pregnant and testing positive for COVID had the same signs of preeclampsia. They had elevated blood pressures, they had protein in their urine, all of those things that we see with preeclampsia, and we actually use to diagnose preeclampsia. And this study just got released, I think it was last month actually, and it shows that COVID-19 during pregnancy is strongly associated with preeclampsia, especially among nulliparous women, independent of any risk factors or pre-existing conditions. So all this to say that we are seeing COVID-19 have an impact on our maternal cardiovascular health. And when we look at it from a severe maternal morbidity standpoint, when the way that we define severe maternal morbidity is by different ICD-10 or diagnosis codes that the CDC has designated as diagnosis codes that would equal severe maternal morbidity. Things like mechanical ventilation, things like renal failure. And these are things that we see with COVID-19. And so you can understand why those patients that have preeclampsia and COVID-19 would have a higher severe maternal morbidity. So why does all this matter? What difference does it make? Why is this important? Well, we know there are long-term effects of hypertensive disorders in pregnancy, whether those hypertensive disorders be because of preeclampsia or because of COVID-19 that may be leading to preeclampsia. Women who experience a hypertensive disorder in pregnancy have an increased risk of cardiovascular disease, of stroke, of peripheral artery disease, as well as cardiovascular mortality. We know that there is a 4 to 8 times higher rate of cardiovascular disease in women that have recurrent preeclampsia, a 2 times higher risk of cardiovascular disease, 3 to 4 times higher rate of developing chronic hypertension, and a 4.2 times of heart failure, as well as an 81% risk of stroke. So all this to say that when we are thinking about our mothers and thinking about those mothers that develop preeclampsia, which sometimes preeclampsia itself is not something that we can prevent, but we do want to have early recognition and we want to have early treatment to help mitigate some of the long-term side effects that we see from hypertensive disorders in pregnancy. So where do we go from here? Well, one of the things is making sure that we're encouraging COVID-19 vaccinations, specifically in our pregnant individuals, our pregnant persons. So the American College of Obstetricians and Gynecologists, the Society of Maternal Fetal Medicine, the CDC all recommend that all eligible persons, including those that are pregnant and lactating, receive a COVID-19 vaccine or the vaccine series, depending on if they're getting Johnson & Johnson versus Moderna or Pfizer. We know that pregnant individuals, if they contract COVID-19, they are at higher rate of having hospitalization, of needing mechanical ventilation, and of death. In the reviews that I do for maternal mortality in Louisiana, in general, that process takes a very long time to get all the records together, to be able to do a comprehensive review. But we are now identifying those pregnant mothers that have died from COVID-19, and we have identified approximately 8 pregnant mothers that will never get a chance to see their baby because they contracted COVID-19 and passed away during the pregnancy from what is essentially a preventable disease. Just if we could vaccinate our pregnant mothers and increase those vaccination rates. And then thinking particularly about maternal cardiovascular health, we need to continue to focus on readiness and recognition. We need support for state perinatal quality collaboratives to implement those initiatives that support maternal cardiovascular health and best practices. You've already seen from the data that I showed you that here in Louisiana, even though it was not sustained, we were able to reduce our severe maternal morbidity by 12% for those individuals that had hypertension. This has also been seen in Illinois and it's been seen in California. State perinatal quality collaboratives are so integral in making sure and helping hospitals to implement best practices. However, there are barriers. In my state, we have 42 birthing facilities that are a part of the LAPQC, and we essentially have 3 team members. We have myself, the program manager, and an improvement coordinator. We have other teams within LDH, other members of LDH that help us, Louisiana Department of Health, that help us with our initiative, but we are a very small team. We need to expand our team. We need funding to do that. There is nothing in our state legislation that makes our collaborative even exist, that mandates that we exist. We do have in our maternal levels of care rule that we are currently updating, but right now we do have our level 3 and level 4 hospitals have to participate with the LAPQC. And so that's great, but really our 1s and 2s are the hospitals that have the least resources that really need to participate with us. Now, I think because we have built trust with our facilities and we've shown how we can lead to improvement, a lot of our facilities that are not mandated to participate with the LAPQC still do. But again, we need state legislation to ensure that we exist, and we need state legislation to make sure that we're funded. We need to make sure for patients, we're doing a risk assessment for pregnant or postpartum patients with cardiovascular disease, to make sure they're getting care by a pregnancy heart team. As Dr. Bond mentioned, those patients are at risk for significant either intrapartum or peripartum or postpartum complications. And so they deserve care that is integrated and that is collaborative amongst an obstetrician, a maternal fetal medicine physician, and a cardiologist. We need to make sure we're getting timely evaluation and treatment of patients presenting with signs or symptoms of preeclampsia. That means not just when they present to the obstetrician office or not just when they present to labor and delivery, but these patients are often postpartum and they're presenting to urgent care. They're presenting to the emergency room. So we need to make sure that we are ensuring our systems of care are coordinated so that ED physicians and urgent care physicians have the same level of urgency when that patient comes in saying, I have a headache, I have blurry vision, and acting on those elevated blood pressures in the same way that obstetricians would, understanding that the pathophysiology and the physiology in pregnancy is different than the general population. And a blood pressure that may not be alarming in the general population is very alarming for our pregnant and postpartum patients. And then our patients need a postpartum cardiovascular assessment visit 3 months after delivery. We need to start thinking about pregnancy. We have made pregnancy as this time that you have a baby, and then 6 weeks after is the postpartum period, and then life goes back to normal. And that's not true. That postpartum period really goes on for a year beyond delivery. So again, we're saying here, best practice is for those patients to have a postpartum cardiovascular assessment 3 months after delivery. However, we know that Medicaid is the biggest insurer, and a lot of patients lose their Medicaid 6 weeks after delivery. So in order to meet this recommendation, we need to see Medicaid expansion so that pregnant individuals have Medicaid coverage at least a year, up to a year at least after delivery, to make sure we're able to continue to care for them. And then I didn't put it here in the slide, but again, as Dr. Bond was saying, and as I mentioned for us for the LAPQC, equity is integral and is such an important part of everything that we do. When we look at the drivers of maternal mortality and we look at why Black women are dying at a rate 3 to 4 times of that of their white counterparts, we have to look at the roots of that. And it is 2 things: implicit bias and structural racism. And so we have to address both of those things. Through the Perinatal Quality Collaborative, we have again addressed equity and implicit bias head on. Even though I will say in the very beginning, it was difficult to do when we were first starting to talk about implicit bias and talk about health disparities. We had teams that walked out on us, did not want to participate with us. And so it is huge to me that here we are 3 years later, and we have all of our birthing facilities working on implicit bias, working on patient partnership, making sure that we're elevating the voice of specifically our Black pregnant patients and postpartum patients in the hospital space. And so we do have to focus on that, as well as the structural racism and the historical racism that has led to these negative social determinants of health that are now causing these disparities that we're seeing in our outcomes. And I thank you for your time. I'll be happy to answer any questions that you may have.
Thank you so much, Dr. Gillispie-Bell, for sharing, the work that you're doing in Louisiana and the findings from the LAPQC and lessons. So thank you so much. Next up, we have Eric Skinner, who's a policy associate in NCSL's health program, where he focuses on women's health and maternal and child health. And he'll be able to provide us some examples of state action to address maternal cardiovascular health. Right, Eric, take it away.
All right, thank you, Kind. Thanks for that introduction. And hello, everyone. My name is Eric Skinner, as Kind mentioned, and I'm a policy associate in NCSL's health program. I'm going to be jumping in with a brief legislative update on legislation that addresses maternal cardiovascular health as we move to the next slide. So my time is short today, as I mentioned, so I'm just going to get right into it. To preface this update, I'll be walking through bills related to bundled payments, Medicaid policy, both coverage related and programmatic policy, as well as telehealth and public awareness of maternal cardiovascular health issues. So I started off with the Virginia and Florida bills because they have a specific focus on maternal health and cardiovascular conditions. The Virginia legislation directs the Department of Medical Assistance Services, which is the state's Medicaid program, to develop and implement episode-based payment models or bundled payments for maternity care, asthma, and congestive heart failure. The bill text states that this is to address both quality improvement and healthcare costs. The bundled payment model has been used in other aspects of maternal and child health policy to reduce non-medically necessary C-sections, prevent complications during delivery, and link payments to health outcomes both for mothers and their infants. The Florida legislation makes changes to the state's Close the Gap program, which is designed to address pregnancy-related complications and reduce racial and ethnic health disparities. The changes promote the use of telehealth within the program for things like hypertensive disorders, cardiomyopathy, which we talked about before, and other cardiovascular conditions. There are non-cardio conditions that are included, and those are diabetes, behavioral health conditions, and hemorrhage, but there's a clear focus on cardiovascular conditions in the context of reducing racial disparities and increasing access among medically underserved populations. This next group of bills simply extends Medicaid coverage past the minimum of 60 days postpartum. The bills often direct the state Medicaid agency to either submit an 1115 waiver or a state plan amendment to the Centers for Medicare and Medicaid Services for them to approve those coverage extensions. And we're seeing states extend coverage to up to 1 year postpartum, as is the case with Colorado, Virginia, and West Virginia. You'll see that Georgia decided on a 6-month extension, so a little bit of variability there, but generally it's up to 1 year postpartum. The maternal and child health community has been vocal about extending coverage in order to screen for and treat conditions that can arise after delivery as a means to prevent maternal mortality and morbidity. As we learned in the previous presentations, we know cardiovascular conditions are the leading cause of maternal mortality. We know that these complications can occur during pregnancy or in the year after delivery. So extending coverage is one way to address these complications and preventable morbidity and mortality. So NCSL has been covering these policies and been aware of them for a few years now, and we're just starting to see some more action on this front in 2020 and 2021. And our last bill here is from Ohio, and it's an awareness bill. It designates the month of May as Maternity Mortality Awareness Month, and it also designates the 4th week of June as Postpartum Cardiomyopathy Awareness Week. And that's to increase the public awareness of postpartum cardiomyopathy, of course, which is a form of heart failure that can happen during the last month of pregnancy or in the subsequent months after delivery. And finally, I have a state health agency action listed at the bottom here. A few years ago, Illinois integrated its federal maternal and child health funding into its Office of Women's Health. So I include this as a reminder of the role state health agencies play in administering MCH programs, but also their role in shaping policy. So, forming relationships with agency staff is definitely good, and it can be helpful, but it's also good to know about recent developments within the Department of Health and just where and how MCH programs fit into the larger state health agency structure. And on our next slide, we have a few links to federal programs that support women's heart health. It's more geared towards cardiovascular health throughout the lifespan, but these federal partners can provide resources or opportunities for collaboration, depending on the type of action being considered by the state. So feel free to explore those links and just learn what resources are available and where these programs are operating. And that will actually do it for me. I hope this information has been helpful, and thank you all for joining us today. I am going to turn it back over to Kine.
Thank you so much, Eric, for sharing those examples. So I'm going to take us into Q&A now. We've got just about 10 minutes left with our experts. So we do have a few questions that came through. Let's see. Dr. Gillispie-Bell, I'll start with one for you. You mentioned, a few recommendations that came out of your work with the LAPQC. Has the Louisiana Legislature implemented any of the recommendations?
Yes, so that's a great question. And yes, they have. I will say part of my role as the medical director of the PQC and the PAMR being under LDH is to be the subject matter expert. So I was very involved in the state legislation this past session, which was a great experience. And one of, I would say, probably the biggest changes or the thing that the biggest legislation that was passed that came out of our recommendations, we have been advocating based on our PAMR maternal mortality review for doulas to be accessible to all patients. We see this as a huge initiative that needs to happen to improve equity. Doulas are so important for patient advocacy and being a voice for the patient. But if for those that don't know, and I didn't realize until the legislative session because the legislators asked me what a doula was. So I do understand it, right? I didn't know, but a doula is a community health worker that helps support during pregnancy and during delivery. And they're not covered by insurance. And so only those that are able to pay out of pocket are able to have access. So one of the legislations that was passed this past session is to establish a doula registry so that we can start keeping a registry of doulas throughout the state with a plan of being able to then ask for insurance doula coverage in the possibility in the next legislative session. And there are other things that have come out of PAMR that have informed legislation and policy. We're working on right now. It's not necessarily state legislation. We're going to do this through rule instead of doing it through a bill, but also upgrading our maternal levels of care to be consistent with the national guidelines. We know that when high acuity patients are taken to low acuity locations, that the outcomes are worse. And so making sure that all of our facilities have readiness, but also facilitating, making sure that the right patient gets to the right care.
Thank you for that. And the next question is for Dr. Bond. Can you share any state or national efforts that you may know of around representation in trials or program evaluations for cardiovascular treatment and interventions, particularly for racially and ethnically diverse women?
Okay, I'm sorry, you were cutting off, but I believe you mentioned national representation in trials. Okay, like research trials or programs, understood. So that's a really important question, especially because as we see right now, at least in cardiology, we know that the inclusion of women, so sex-specific research, as well as even racial minorities in trials, it's very, very low. The actual percentage is about 30% at best, and those are for our larger studies that focus on heart failure or even coronary artery disease. What I will say is that the NIH several decades back actually made a mandate through a public health campaign that we needed to be very transparent in terms of who we include in our research trials. Despite this, we still see that we are not doing as good as we could when it comes to making sure that our population that we're actually studying reflect our standard, very colorful population of the United States. So a lot of the efforts that we are doing are at the grassroots through our local health systems, as well as our cardiovascular societies. All of our societies, ranging from the American College of Cardiology, the American Heart Association, as well as the Association of Black Cardiologists, their target is to increase inclusion and really come up with collaborative ways on how to do that. I think one key point is to, as I focused on as well, is to get to the community leaders, especially if we want to diversify those that are coming into research studies. So we really have to go to the location. So bring the community leaders and trusted members into the discussion. So hopefully we can diversify the number of people that we're actually studying, because it is very important that we have targeted research for those vulnerable groups.
Yeah, thank you. Just a follow-up for that. Is there a role for state legislators in going into those communities or helping with enrollment at all? Have you seen that happen in other states?
So I think that that's also a very important point, and I think something that I would 100% support, and I think a lot of our societies would support as well, because the more at least collaboration we have and just all working together for that commonality, I think that we actually will see said change. So that's something that I'm hopeful that, depending on all states, because it's not one state versus the other, we're seeing this across the United States and even nationally and internationally, more importantly, that this is something that I think we have to take very, very seriously, because we know that if we're not actually studying from an inclusionary perspective those vulnerable patient populations, we may not be providing the appropriate management and treatment. So I do think that having a state legislator who's thinking about incorporating this into their policies and plans would be phenomenal. And I could imagine that many of our medical societies would love that and want to work with them.
Thanks for that. And on the topic of engaging community, Dr. Gillispie-Bell, can you talk about how the Louisiana Department of Health's about the department's efforts to engage community stakeholders in your maternal health work?
Sure, absolutely. So I'm going to speak about it, I guess, in several different ways. Through the LAPQC, we have an advisory board. And our advisory board has several subcommittees, and one of those is our community health workers. When I initially took on the role, we had a large advisory board of payers and health systems and community workers and policymakers. And we didn't feel, even though we all still meet together as one big board every 3 months, we didn't feel that the voices of those community workers were really being elevated just because of all of the competing voices. So we broke this down into subcommittees. And so the work that we do through the LAPQC is definitely advised by our community organizations, community workers. And then we see ourselves, because LAPQC is not patient facing, we're more hospital facing. So we see ourselves as the bridge between the hospitals and the community organizations, all caring for the patients at the center. Through our PAMR, our Pregnancy Associated Mortality Review, as I mentioned, we now do a much more comprehensive review. We review all deaths, regardless of the cause, up to 1 year, if they were pregnant at the time, or up to 1 year at the termination of the pregnancy. And when we do this review, we have not just obstetricians and not just maternal fetal medicine specialists, but we have cardiologists, we have violence preventionists, we have social workers, we have DCSF, we have a patient, we have midwives, nurses, we have other doulas, other community organizations as a part of that maternal mortality review to make sure we're doing a 360 holistic review of all of those causes, all of those social and community factors that may be also contributing to maternal deaths. We again have to think holistically about patients, and especially if we're thinking about, as Dr. Bond and I have already mentioned, the disparities that we see, then we have to think about those social determinants of health, and it takes those people that are in the community to be able to communicate and understand those things. And then additionally, we've already kind of talked about the doulas. So the doula registry board is all composed of doulas that will be deciding what the requirements are for that registry. So definitely a lot of communication and collaboration with community organizations.
So much. We are coming up on the end of our webinar, but we do have time for any last minute questions. So get those in if you have anything burning, or always reach out and we're happy to follow up. But I will ask each of our external experts to just share, any final last thoughts that you would like to share with our audience who are NCSL members and state legislators and state legislative staff. We'll start with Dr. Bond.
Yes, thank you. I just want to say thank you again for the opportunity to present today. I do want to end by highlighting the fact that we know that life expectancy, which is something that really dictates health outcomes very nicely when it comes to even cardiovascular disease, but life expectancy in general. We know that there are disparities in the sense that we know that non-Hispanic Black men as well as women have the lower life expectancy. Now we're seeing with COVID-19, that's actually played a much larger role. And my concern is that even data looking at the first 6 months of 2020 has highlighted the fact that our life expectancy, if you're a non-Hispanic Black male, has dropped by 3 years and a non-Hispanic Black female by 2.5 years. And these are the women, when we think about, again, maternal care, that are at the greatest risk. So as we've heard throughout all of the talks today, what COVID-19 will be doing in terms of that exclamation mark on maternal mortality, it concerns me immensely. And I think that my hope is that through collaboration at the legislative level, as well as the medical society level, the clinician level, community level, we can all make an actual change, making sure that we're caring for these mothers that are the most vulnerable. So that's what I would like to leave you all with today.
Thank you. And Dr. Gillispie-Bell?
I first just want to say thank you for allowing me to be here today and allowing me to give my perspective. I feel humbled and honored to be able to be here. And then my last plug I would give is for supporting state maternal mortality review committees, as well as state perinatal quality collaboratives. It is so important to have that data to action model. And again, not just in Louisiana, but Illinois, California, Florida, we are seeing positive impact and positive change and improvement on maternal morbidity, as well as, and I'm sure mortality is going to follow, because as Dr. Bond mentioned, mortality is just the tip of the iceberg. But we're seeing that positive impact, but we need support. Every state does not, almost every state has a perinatal quality collaborative, but it looks very different in different states. And almost every state has an MMRC, but again, it looks very different. Some are housed within universities. Some are 5 people that got together and said we needed to have this, and they're starting to organize it. So please, if you have that ability, and legislatively would be the way to do it, please support the establishment and the sustainment of maternal mortality review committees and PQCs.
Thank you. We are unfortunately out of time today. So to our audience, if you have any questions that you didn't get a chance to ask today, or that come up as you're thinking about all of the information that was shared today at midnight tonight, please don't hesitate to reach out to our team. We're always happy to answer your questions and follow up later. So we would like to extend a final thank you to our presenters. We greatly appreciate your time and the expertise that you shared today. And thank you so much to our attendees for participating. As a reminder, a recording of today's webinar and the slides will be available on the NCSL website within a week. Well, have a great rest of your day.
Thank you.
Thank you.